Morning, everyone. So we've been hearing a lot of sort of expert talks, if you like, and I guess quite a few people are here because they're thinking about starting some of these things. So I just wanted to share my experience of starting a MIDCAB program, and if you're here thinking of starting one, just give you a bit of a framework to approach it. So I think there are 4 real challenges when you're starting either as a new surgeon or starting a new service in your hospital. I was appointed in August 2010, and I was doing MIDCAB. I started doing MIDCAB about 6 months later. And when I first started to think about it, I sort of divided the challenge into 4 bits, really, and that's going to be the way I'll approach the talk. I think you need to convince yourself that you can do it, and you have the skills and the wherewithal to actually deliver the results. Obviously, you need to have the support of your colleagues. You need to find the work from somewhere, and of course, someone's got to pay for it. So when I started, I'd seen some MIDCAB. I hadn't done any, but I'd seen some in Bristol, about 10 cases or so. But to my mind, there were 2 main hurdles that I had to get over. One was the off-pump anastomosis, and the other was taking the mammary down. I was an off-pump surgeon. I'd been trained in Bristol, so that wasn't a problem. And I'd done some thoracoscopic or thoracotomy lemur harvesting, but in the setting of multi-vessel disease through a conventional thoracotomy. So I had some experience of attacking the IMA through the left chest. I'd started at James Cook 6 months previously and started doing off-pump as a new procedure there. So I knew I was in an environment that would allow or foster the development of a new service. And I think those are the key things that I thought I needed to have before I could start doing a new operation. You obviously have to convince your colleagues, and as someone else alluded to earlier on, the first thing you get when you start to say, I want to do this operation, is that we never do this operation because we never get the patients. We only get 1 or 2 a year. It's never going to be any more than that. And that makes the second question, which is, can I have all these patients, quite easy, because most people would be quite happy for you to have that practice because they don't think there's going to be much of a practice. It's always worth looking at the data to see what's happened before, but the key thing you're going to try and achieve with your MIDCAB program is completely change the way these patients are managed. So don't be put off. There won't be many cases, but it's about changing the whole ethos of managing these patients within your service. Convincing your cardiologist, well, it starts to get a bit more difficult now because obviously you need to get these patients away from their service into your service. And the way to do this is by building relationships. We have 4 MDTs in our patch, 5 now, from Sunderland all the way down to James Cook. And you have to populate these MDTs, and you have to make your case. Most of you remember Mark de Belder. He was here about 2 years ago giving a very staunch defense of PCI. These are the kind of characters that you have to deal with. So how did I try and get by this? Well, I think the guidelines were really, really helpful. There's a European guidelines at the top and the American guidelines at the bottom. And turning up with MDTs time and time again and using these guidelines to make your case, I found very useful. I think these sort of images are very useful as well. That's obviously a patient who's had a conventional operation, a patient who's had 2 patients who've had MIDCAB. And again, these sort of images are very helpful when you're trying to convince your cardiologist that you're offering something completely different and that their patients will be better served with surgery rather than with a stent. And then, of course, you've got to convince someone to pay for it, and they're quite expensive operations, both in terms of the disposable cost and the time taken to learn and to deliver it. And you do this by selling the potential benefits. It might be that you get new referrals or a new cohort of patients that you don't normally see, and that's the whole point, that these patients will use less resources, either because they'll stay for a shorter period and it'll be in ITU for less, or use blood, etc., etc. And it might be an opportunity to really innovate and to introduce new things. For example, changing the patient pathway through use of day of surgery or ITU bypass protocols, etc. So you have to sort of find out where the weak spot is, if you like, and exploit it in your unit. So how did I get on? I was appointed, as I say, August. I started MIDCAB 6 months later. I did the first operation with a proctor. George Asimakopoulos from Bristol had been doing these just as I was leaving, so I got him to come up, and we did 2 cases in a day. And I started the program around the time that the guidelines were published, and as I say, that they were really, really quite useful. So this is the sort of thing you hope to see when you start your MIDCAB program. The first column shows what was happening before I joined James Cook. So there's a 2.5-year period. 6 patients had a lemur to LAD operation, and that's what you'd expect, and that's why there's a lot of skepticism when you start talking about it. But the far column at the end, that's the red column, are the number of referrals I got in the 12 months since the program started. So 45 new patients referred, of which 30 had a MIDCAB. So a complete change in the way these patients are managed, and this is what you're hoping to achieve. So don't be disappointed if they aren't being done. The whole point of starting the program is that you're going to change the way these patients are managed. You need to keep the momentum, obviously, and the way to do that is to keep on collecting and presenting the data, because they're going to convince them to carry on sending you patients. They're going to want to see some results. And this is how I've got on in my first year. So I've done 30 cases, and I've converted 4 of them. But as you'd expect from this sort of cohort, the major morbidity and mortality is really quite low. Post-operative length of stay has been the biggest benefit that I've seen. The median length of stay for my patients have been 3 days in the 30 cases I've done so far. Those are the first 17 patients, and everyone goes home at 3 days except 1 or 2 patients. And that's the sort of thing that your hospital would like to see, and your cardiologist as well. Other complications are low atrial fibrillation, blood transfusion rates, and post-operative blood loss. So what have I learned, and what do I think is important when you're trying to do this? Well, I think you have to be, to my mind, selective to start with. I turned down 15 of the 45 patients I was referred for a number of reasons. I think it's very important that you don't take on difficult things like obese patients, patients who can't tolerate double lumen tubes, as Tony D'Souza said, and patients who the LAD anatomy is unsuitable. So I think you need to pick your punters, if you like. I kept it quite simple. I avoided doing multiple grafts in the first year. I just stuck to doing lima to LAD grafts. And I converted if I was worried, and I didn't persist and carry on. And the patients who were converted generally actually did quite well, because they either got a rema to the LAD if the lima was damaged, or went in and got a conventional operation if the conversion was for some other reason. So just to summarize, I think the patients are out there. I think actually, you know, if you look at your cardiology data set and look at how many proximal LADs are being stented, there'll be loads. That the challenge is to try and convince these patients to come into your service. I think the MDC and the guidelines are very useful, and I've certainly benefited from using those. And I think it's a good operation. I think you can do it with very low morbidity and very low post-operative length of stay. And that's going to be your main tool for keeping the momentum and keeping these patients coming your way. And to start with, I suggest you keep it simple and be selective. Thank you.
Questions, but again, if we maybe change over the slides, and then we'll ask some questions.
Thanks, Ian. Can I just ask the increase in referrals?
I know it's next. I've just answered the question. Sorry, what was that?
Sorry, yeah. Thanks very much. The increase in referrals, is that because the cardiologist is sending you more isolated lima to LADs, or because they're sending you 2-vessel disease where they stent the circumflex on the right and leave the complex LAD for you?
Okay, the referrals sort of...
just out.
The pattern of referrals were that the first few patients I got were patients who've had PCI and had failed. So that's the first sort of tranche of patients that I got. And then I started getting patients where they thought, well, this looks quite difficult, either because it needed rotablation, etc. I haven't really started getting patients where they haven't looked at it, or I haven't got easily stented lima to proximal LAD disease that they would normally take on first. So I think that's how it starts. It starts with things that they can't do or things that they tried to do and have failed. I had, as you saw, there were 9 patients who I got sent with multi-vessel disease. And the typical letter you get is, I've got this patient with proximal LAD disease. I think that's a critical lesion, but there's some right coronary artery disease. We'll treat that, if you fix the proximal LAD. And in general, I've adopted the strategy of just doing a conventional operation in those patients. So I've avoided doing hybrid operations. I think the evidence for the hybrid approach is not very good. The little evidence that's there is not very good. And I think if I was to do that, I'd want to do that in the setting of some sort of study or trial.
Dimo, you mentioned when you're starting, you avoid patients who are obese. What was your cut-off for a BMI then? Did you not have a cut-off for just eyeball the patient?
Very much so. I think the shape of the patient as well is very important. It's not a very easy operation in a short, fat, obese lady. I think that combination is the most difficult combination.
In terms of the angiographic things you want to look at,
think the most important thing is you need to have some flexibility in where your anastomosis is going to be. So I think if you feel very limited because, for example, you've got a very long segment of disease, you suspect that the vessel might be intramyocardial, there are lots of stents proximally, I think those are things that would always raise a red flag for me. I think I'd like to have a lot of flexibility about where I'm going to put my anastomosis.
I don't think I'll be that dismissive of the hybrid procedure because we've done it for about 10 years. We've done about just under 100 cases. The Achilles heel of the hybrid procedure is in the stent. Yeah. But you must remember, if they didn't come to you, often they've been stenting it already anyway. Fortunately, the problems that we've had with hybrid procedures have just ended up having a repeat stent.
Yeah. I think that is true. That's what the data shows as well. But I think having got to me, I sort of feel that I ought to do a proper operation. But you're right. I think if you're going to do the hybrid procedure, that the Achilles heel is always going to be the stent.
One of our academic cardiologists thinks that all we need to do is put a limit to the LAD.
Yeah.
We can forget about the rest,
Yeah.
and usually, he's begging for us to do a trial on that.
You know, can I ask? I've seen MIDCABs being done. Every time I go in, what gives me a sort of visual pain is the way the costochondral junction is being sort of lifted up. Do you have any tips or tricks to avoid? Because your patients seem to be doing really well and going home very quickly. Is that because it looks painful?
Yeah, no, it does look painful. I have to say, it just hasn't been a problem for me. I don't do anything particularly special. I put paravertebral blocks in, and because a lot of these patients are young patients, they can have non-steroidal, so they tend to have non-steroidals as well. I guess with experience, you lift a lot less, you learn how to position the patient a lot better, you're predictably in the right space, all those things make a difference. It looks painful, I agree, but they do sort of get up and about and go home early, and it hasn't been a big problem.
Next question.
Very nice presentation. Three questions, if you don't mind, very briefly. Just in response to that particular issue, I suspect that you're doing exactly this. I learned a very important trick from a surgeon in Milan when I started doing the MIDCAB program some years back, and that was that he would actually make a small incision quite laterally and not take the costal cartilage out, and then dissect the intercostal space very laterally as well.
Yeah.
And that would allow the ribs to open
apart
laterally rather than medially.
Yeah.
I suspect that's exactly.
Yeah, no, that's a very
important. Because it would be no
important.
other way for you to get the outcome that you're getting. So that's excellent. But just two other things. Obviously, there's been some guidelines looking at intraoperative flow rates down conduits for all patients undergoing coronary artery surgery. And as critical as one might be about those sorts of parameters and the sorts of instrumentation we use for that flow rate measurement, do you think there's a greater obligation to study patients who undergo MIDCABs in some form post-operative? Because that's the biggest question that most people ask when starting a MIDCAB program. And the third question is, what technology are you using for your program? It's clear it's been very successful.
What technology? So it's mostly metronic-based equipment really. So I use the Thoratec retractor, and I use the Nuvo stabilizer. I started using a conventional stabilizer, but actually you can do it with a conventional stabilizer, but it is more difficult. The Nuvo is more fiddly, but actually once you're stabilized, the anastomosis per se is very much similar to an open off-pump lumos or a leading anastomosis. So I think that makes a big difference. Which, particularly in terms of your second question, which is the quality of the anastomosis, I couldn't agree with you more. I mean, I think for all operations we do, it'd be really good at the end of the operation to know your graft is working perfectly. And the answer to your question is yes, of course it would be great if we could afford to do that. But as Joe said before, it's the cost of getting that service, and that's the thing that's stopping me from doing it. But yeah, I guess, and that's the other thing with the hybrid. I guess the advantage of the hybrid is that if you're particularly doing it that way, doing the anastomosis first, then you do get an angiogram to make sure your graft is okay, and that would be one possible reason to do a hybrid.
Thank you very much indeed. That's excellent presentation.